مساء الخير دكتور
بسم الله الرحمن
عصام.
Thank you, Dr. Mohammed. Thank you for the great organization and for the invitation as usual. And it's my pleasure to moderate this session around advances in dry eyes, one of the very hot topics in ophthalmology in the last few years. We'll hear from different aspects, medical and surgical. And let's start with Dr. Rohit Chetty, talking about the mysteries and controversies in dry eye management.
Thank you, sir. And I have already uploaded my presentation. If somebody can load it up, please. Hello, friends. I'm Dr. Rohit here. Thank you for this invite. I'm going to speak about mysteries and controversies in dry eye management. No direct financial interest, but I do have research grants from Allergan, Novartis, and other companies. Dry eye today is classified into two common things. This is the major controversies and mysteries. One which has symptoms and signs match, one which symptoms and signs don't match. When they don't match, you may have an ocular inflammation, dysregulated ocular nociception, neuropathic pain, and your conventional treatments sometimes fail to treat them. So we submitted this paper which is in review now. We call it the discomfort discordance to signs grouping. Let's call it discordance is D, and sometimes the discomfort is more than the signs. These are all the big challenges for the dry eye specialists today because they don't really match. So this particular paper with Use AI use this classification to make it more understandable as we move on. For example, when you have a lot of pain, then in the confocal microscopy, we see a lot of inflammatory cells called dendritic cells. So even if you don't see them, it's there. It exists somewhere in your eyes. Sometimes you may have a lot of pain, neuropathic pain, and you could see this microneuromas out here. These microneuromas could have a lot of pain factors, and these patients may have absolutely no sign, absolutely normal T-but tremors and everything, but they could have pain. So this is the controversy and confusion out here. So the question is, can we identify these molecules? Can we look at targeting them specifically? So we have to move out of our old ways and start looking at these molecules. There are a lot of molecules. I personally worked on these main ones because they are directly linked to it. For example, matrix metalloproteinase 9, MMP9, interleukin 17, ICAMP1, interleukin 1B6, a lot of them. So what we did was to change the way we look at it. We built a point-of-care diagnostic kit called a lab on chip, where you can use the tears into these wells out here. And these, when you use the bells, there are antibody-coated tests, which gives you a report very quickly. This is used in the outpatient. You take the Schirmer strip, waiting period, and once you put it in an Epindrop tube, this is one of my fellows. They use some diluent, and after that, you shake it for some time. Once you shake it for some time, take the proteins out, put it into this cartridges out here, and read that cartridge is put into a HeLa diagnostic machine and gives you a readout within 60 minutes. And this is what happens. All this one in red are the ones which is elevated, which has a reference thing here. So what we did was we built a concept called the biomarker-enabled specific targeted therapy, what is called the best therapy, using the biomarker kit, which is that lab on chip you saw. What we do is now, using the same classification what I just showed in the past, we know that these 4 classification of patients have these types of molecules which are higher or lower. And how do we know? Is based on these reports here. Based on these reports, these molecules which are higher, you can choose what medicine to treat. If, for example, if you have an ICAMP1 which is higher here, which is in this case, you can choose a liftigras or Zydra, C steroids, or you can use an IPL or lipiflow therapies. If the MMP9 is very high, based on the values, we also have a normal values given out here. You can choose what type of lubricant. If it's a lower MMP9, then you don't worry. Then if it's higher, use a cyclosporin, or you can combine cyclosporin with a steroid or for a longer time, 3 months, 6 months. If it's very high, more than 3 lakhs, you can use. There's a completely new dimension of how you titrate your treatment. It's like insulin. So when you give insulin, you titrate based on the sugars. It's exactly the same thing. Let's discuss some case. A patient had a burning sensation, LASIK 2 years ago, very high OSDI, drops not working. You can see the MMP9, 49,000. The patient has close to around 3 lakhs or 32 lakhs. High levels of inflammatory markers. We have published that inflammatory markers can be treated with with your IPL treatment. We treated him, and look at this, MMP9 from 32 lakhs just became to 4,000, and the patient completely became all right. Otherwise, this patient would have been given multiple steroid, multiple drops. Look at this, everything comes back to normal, and you have an extremely happy patient. So what I'm trying to say is, we can target it, and you can, like this, we can have multiple targets. If this patient had a high level of IL-6, we could have target ICAP1, could have given him a liftigrast. We are also using this to look at VEGF in ROP, to look at progression. We're trying to work in the future on dopamine. So in summary, there is a huge amount of controversy revolving the dry eye, but we need to look beyond our comfort, beyond what is being seen, by looking at biomarkers, new imaging, even building an AI. That's what my areas of interest is. So this is what is going to be the future of the dry eye therapies. These are my team. It helps me to build this work, and my group of consultants. Thank you, and I'm ready to take up questions.
Thank you, sir. I think we'll leave the questions till the end. And now Dr. Osama Giledi can talk about the role and management of meibomian gland dysfunction in dry eyes. Tfaddal, Dr. Osama.
Thank you. Thank you very much. I just so try to share the screen. So basically, I'm talking about the role and management of MGD in dry eye. As you know, the ocular surface, they have a tear film, which is they have 3 layers. The outer layer, which is very important nowadays, we consult, is the lipid layer, which is secreted by meibomian gland. We had almost 20 to 30 meibomian gland in upper and lower lid, and if it's the secretion not normal, that will affect what we call the tear film breakup time and the quality of the tear film. The meibomian gland dysfunction, before they call it posterior blepharitis, is it's one of the common eye conditions. We see it daily. And MGD is often a cause of a dry eye disease. There's different factors why people had MGD. Age, it's common with age. It's more common with women also, a deficiency of androgen. But systemic disease like Stevens-Johnson, Sjogren, psoriasis, atopy, polycystic ovary, hypertension, that also sit with the meibomian gland dysfunction. Ophthalmic factor, people had iridia, they don't have maybe meibomian gland at all. But people had chronic blepharitis, people wear contact lens, lid tattooing, trachoma, that all contributing factor for MGD. Dermodex mites, also another infestation in the lid, cause the inflammation of the lid. Acne rosacea and the treatment, Accutane, both of them is a common factor for MGD. When you examine a patient with meibomian gland dysfunction, the lid margin become round, hyperemic, the secretion is cloudy, thick, yellowish, and when you press it, it's like waxy and like a toothpaste, doesn't express easily. As you know, the vicious cycle of dry eye disease is that there's a tear film stability, hypersmolarity, apoptosis, inflammation, but there's another cycle what related to the MGD, which is related to the bacterial flora, release of steroids, and the steroids causing inflammation. And the inflammation causes keratinization of the meibomian orifice, and also the inflammation increase the melting temperature of the meibomian, so the meibomian secretion is stuck in the gland, and the gland, when it's obstructed, becomes stasis, cause inflammation, and the end result cause atrophy of the meibomian gland itself and cause another vicious cycle, worsening of the condition. Initially, all people talk about dry eye as aqueous deficiency evaporative, and evaporative is the most common cause is the meibomian gland dysfunction. The tear film breakup time is one of the main indicators for meibomian gland dysfunction. It's very easy tested, use a fluorescent, and you look into the tear breakup time. But nowadays people move it to use non-invasive breakup time because not operative dependence. But the problem is a bit expensive, need machine, and basically look into the placebo disc and break of the tear in the individual. You could also use a machine to look to the lipid layer thickness, like LipoView, and the quality of the tear film itself. When you examine the patient with meibomian gland, always try to press in the lid, either with cotton balls, or you could use the Corp meibomian expressor to evaluate the meibomian gland obstruction and the quality of the meibum. But also you could use a scan to the meibomian gland to see the morphology of the gland and assess the quality and the quantity of the gland itself. Like this example, patient had the Roaccutane treatment before Roaccutane, and after 1 month, as you see that there's a drop of the meibomian gland, and the meibomian gland become obstructed, and the Roaccutane take almost 6 months for the meibomian gland function to regain its normal activity. Generally, people with meibomian glands function and dry eye, patient education is very crucial. There's a lot of studies show good health, fish, nuts, and all omega-3 that tends to help. Contact lens is a risk factor, so people should avoid contact lens, especially overusing it, and protective glass guard can't help. Artificial tear, as you know, the mainstay treatment of dry eye disease, but when you had meibomian glands function, you may need to think about oil containing emulsion product. Always remember to avoid the preservative and the bag for treatment for dry eye and MGD. And nowadays in the market, really good, we have a lot of artificial tear, and many of the new one also, they have a oil component like Liposec Gel, Artilac Complete, Cationome, Optive Plus, System Plus, and there's many, every time they have more. So we are lucky nowadays, there's much more awareness of the dry eye and the composition of the treatment available. Inflammation, as we know, is very important role in the MGD and for dry eye disease. Corticosteroid, still we're using it, but we need to use it for a short time. For MGD, I usually use the ointment because it stays in the lid more, but cyclosporine, tacrolimus, levetiracetam, all of them, that's very good long-term maintenance. Azithromycin, tetracycline, and doxycycline, they have antibiotic, but also they have anti-inflammatory action and lipogenic action. So they promote the meibomian gland to secrete better meibum. I shifted nowadays to use azithromycin more, either oral or topical, because it's really as effective or even better than doxycycline, which we have to use it daily for a month, and can cause tummy upset, toxicity. It has very high tissue penetration. It has a long half-life. So when you give a course, it will stay in the body much longer. It can be given in pregnancy. Usually I give it 500 milligram daily for 3 days. Some people use 500 for a day, then 250 for another 5 days. But you could repeat it after 2 to 4 weeks. Topical, usually do twice a day for 3 days. The problem with the topical is slightly burning, and we always explain to the patient they may have some irritation initially, otherwise the patient compliance will become poor. Warm compressive massaging really still a best treatment. We should educate the patient how to do it. It's almost like 5 minutes warm, and then followed by massaging, and it's good to use lid wipes. Some people, they have their own goggles, they would steam with heat, and some people prefer, but it's expensive to buy it yourself. The other modality, what you call thermal pulsation, like a LipoFlow or Ilex, which is basically a machine creating heat, then followed by massaging to the meibomian gland, express them. Both of them, LipoFlow, Ilex is FDA approval, but the problem is expensive, and it's not a cure. So people need to have it every 6 months or every year. And always tell, even if they have this one, you have to ask the patient that you need to keep the warm compressive massaging daily one. The other modality, which I use it more, is intensive pulse light, IBL, which is usually we're using a burst of specific wave light over the lid, usually the lower lid. The mechanism of action is multifactorial. It's shrinking the microvasculature to increase the temperature, so it melted the meibum, and also reduce the bacterial flora, but also it trigger the what you call liberation of neurotransmission by parasympathetic stimulus, which is stimulating the meibomian gland as its function and the contraction of the gland. It's IBL is FDA approval for patients with rosacea, and that's and acne. Basically, initially people use the IBL for treat rosacea, and they found their meibomian gland improved. That's how they detected. So the dermatology, they are the one who told us that it's very effective for MGD, by the way. It's very simple. It's just we do like a session 1 day, and then 2 weeks, and about a month or a month and a half. Usually different manufacturer recommended different setting, but it's usually like in the lower lid only. but always I do meibomian gland expression after I do the session itself. It's very safe. The only thing is doesn't cover by insurance. So there's the cost implicated. The other modality, what you call lid microexfoliation, which is really basically is very cleaning the lid by more brushing motor sponge. That's debride all the debris, and it's good for people who had dermodex. The other modality people use, I don't use myself, really what you call intraductal probing and expression. Basically, it's you just go with the probing to the meibomian gland, but it's time consuming and irritating to the patient. But I use sometimes forceps to squeeze the lid after IBL. In general, the dry eye treatment, usually if aqueous deficiency, usually talking about artificial tear, gel ointment, or punctum plugs. But the evaporative, there's too many modality we use it. As I mentioned, steroid, usually we use it with ointment with antibiotic like Tobradex at night for a couple of 2 weeks. Omega-3, doxycycline, azithromycin, scrap, warm compressor, thermal IBL, and exfoliation. Cyclosporin, levetograph, steroid, autologous, that work in both aqueous and evaporative. As we know, most of our dry eye really is a mix between both evaporative and aqueous deficiency. In conclusion, there's more awareness now about the role of MGD in dry eye disease and important to diagnose and treat it. There's many new ways available to better assessment and monitor and treat the MGD. Inflammation play a very important role in MGD. Lipoflow IBL is very effective to treatment, but it needs to repeat it, but it's not a replacement for the basic warm compressive massage, because the patient sometimes he think you do this session and then he'll be cured. So always be very important to educate this patient. This will help him to recover quicker and promote the recovery, but he need to do the basic warm compressive massaging himself. And that's why patient education about dry eye MGD really is very crucial for the treatment and the compliance, because otherwise the patient start to move from doctor to doctor. He think there will be one single cure, but that's very important to sit with your patient, explain to him very well about the disease, and that will be, you have more happy patient. And thank you very much.
Thank you so much, Dr. Osama. Very nice review of meibomian gland dysfunction. And now with Dr. Safwan El-Bayati for the role of long anti-inflammatory use in dry eye treatment.
Good evening, everybody. Good evening, Dr. Isam. I think that they need to share my presentation because till now, yeah, I think that Dr. Rahit, Professor Rahit, and Dr. Osama, they gives me an open road to go through and discuss an important issues, the role of this an anti-inflammatory treatment, the long acting anti-inflammatory in the dry eye. Now, Dr. Osama was concentrating on meibomian gland dysfunction, MGD, and generally when we are looking through with all our measures to diagnose any dry eye, we are returning back to the vicious circle that creating the inflammation, and the inflammation as a rule in or the main role in creating the dry eye. That's right. In MGD, where it's very obvious, we can go through and start the treatment with all the steps that Dr. Osama, he's a pioneer in a dry eye, so he mentioned it, and it was a comprehensive review, but still there is a role for anti-inflammatory in all the elements that it's been mentioned. And Dr. Rahit, he mentioned the role of liftographs, for example. That's what I will present today, and what its importance in break this vicious circle to stop this inflammation. That if we will go back to this circle in a little bit details, we will see that this role of inflammation that started from tearful instability deficiency, that which for a lot of reasons, that one of its MGD, and the other of its which nowadays more frequently is the use of devices that create damage, or any cause that can create damage to the goblet cells. So MGD and goblet cell deficiency will lead to the hyperosmolarity, and hyperosmolarity will lead to a cell damage and apoptosis and nerve stimulation and inflammation and the cytokines release and this cytokines release end up with the goblet cell loss, and then the vicious circle will be continuous, and we will continue having the issues. And so our role is to break up this vicious circle, and the rest of the circle, I think that Dr. Osama was clearly mentioned it. So I'll go and summarize it. And now, what's the role of this anti-inflammatory that we are talking about? And why long-acting? Why I'm not talking about steroid here? Because those patients, they are chronic. So we need a long-acting, and that anti-inflammatory can break up the immune synapse. The LFA receptor on T cell bind ICAM1 on the antigen presenting cells, forming the immune synapse. This immune synapse that will activate and express the ICAM1 on the antigen presenting cells, the T cell recruitment to ocular surface, T cell migration into ocular surface, T cell activation, the release of pro-inflammatory cytokines, and T cell binding of antigen presenting cells. So breaking up of this immune synapse is the rule, is the aim of this inflammatory, or of our inflammatory anti-inflammatory medication. So here diagrammatically it shows clearly that how the anti-inflammatory medication will bind the LFA, preventing that receptors from binding to ICAM on the antigen presenting cells, and break the existing and prevent the further. So it treats the existing and prevent the further. So it's we can use it as a treatment. So that's why it has an effect, can appear on the patient within 2 weeks, and it prevents the further inflammation. And this movie, a short movie, can show this effect.
Specifically designed to target a source of inflammation in dry eye disease, it is thought that Zydra targets both inactive and active T cells, thereby helping to disrupt the continuing cycle of inflammation. Zydra blocks LFA1 on inactive T cells from binding with overexpressed ICAM1 on the ocular surface, and may prevent formation of a specialized cell junction between specific immune cells, which may inhibit T cell activation. Zydra is thought to inhibit migration of activated T cells to the ocular surface and may reduce cytokine release. Zydra is a first-in-class prescription therapy thought to target both active and inactive T cells in order to interrupt the chronic cycle of inflammation.
So, from this point of view, patients coming, majority of them, if we will divide according to the epidemiology, only 10 to 15% we have those patients with aqueous deficiency, but the majority, they are in between mucin deficiency and meibomian deficiency. Now, in my practice, I'm seeing around more than 60 to 70% they are presenting with the mucin deficiency. Their meibomian test, I'm doing all the tests, whether it's direct breakup time or non-invasive mapping of the cornea, and seeing their tear breakup time. Definitely, it's very difficult to differentiate between them, but they don't have any signs and symptoms of lid margin inflammation. So most of them, they are in categories of mucin deficiency. They might be present with only irritation, without redness, no swelling and no pain, but only irritation, discomfort. They cannot blink. There is a blurring of vision, and the stinging sensation. Those are the majority of the patients that we are seeing in our practice. My main test that I'm depending on it is the breakup time. Now, Schirmer test, corneal staining, tear osmolarity, and the diagnostic imaging. However, the tear film osmolarity can give a clue when the tear osmolarity is over 300, the normal that exceed 316 milliosmol or higher, that give a clinical indication on, clinical indicator of inflammation, and directly correlate to the level of inflammatory mediator and MMP9. The higher the osmolarity, 100% there is an inflammation, but it's not a specific to a dry eye, because any inflammation that can create this osmolarity. That's why we cannot depend on the MMP9. So my concern is that is the breakup time and the corneal mapping that shows tear film, especially for those that they cannot use the breakup time or they have any irritation related to the fluorescein. So I'm doing the corneal mapping. Patient with dry eye disease display an array of inflammatory marker, as I said, but still the test of higher MMP9 is not a direct correlate to the dry eye. That's why it's positive, it's useful in following the case when we are describing it, but it's not a clue that we have a dry eye when we have a dry raise. And that's the test of MMP9. Now, if you will go to Zydra studies, they recommend in the first 3 arms, the aqueous tear deficiency and blepharitis due to meibomian gland deficiency or dysfunction, and the goblet cell deficiency, the 3-arm, the anti-inflammatory use of liftgrass is useful in those 3. And it's play a big role in controlling the symptoms and sign within the first 2 weeks. If we will go to when I need to use the anti-inflammatory, the Zydra liftgrass, in my practice, I found that when the breakup time less than 10 seconds, Schirmer test less than 5 millimeter, and there is an inferior corneal staining. Now, if we will go to these tests and shows, this movie shows that a 45 years male with a breakup time less than 5 seconds, and you can see, hopefully that all the illumination is clear in a way that we can see it. I'm trying to see, but this is here it started, and I will try to increase the illumination and repeat the movie if it's. So it's appear that within less than 5 seconds, the breakup time here, it was very significant. The patient was irritated, and he's definitely a long users of computer and the direct phone, all device. If we will see to this movie, this is 2 weeks after the use of Zydra, and here I'm using Zydra with artificial tear, and we will discuss the type of artificial tear. We can see that the Schirmer tests enhanced to around 16 seconds, sorry. He was very happy. Now we will go to the second case, 36 female with a breakup time 2 seconds, and you can see that once you put the fluorescein, the breakup time started. So it was very irritating. Now the patient forcing herself to prevent blinking. And if we will see 2 weeks after use of the anti-inflammatory Zydra, we can see that it's much better. In spite of that, the Schirmer test is not improved a lot, but the patient was much comfortable than before. Now, what about this test? Now, I'm instructing definitely our patient, addition to the use of anti-inflammatory, to blink. And most of our patients, they try to remember when they are using their devices to blink. Blink is the main issues to polishing the cornea, remodeling and get rid of the dead epithelium and wetting the cornea. So that's why there is a software application on the Apple and in Android called Eye Protector. This Eye Protector is a free, and they can download it, and we put it as a small papers that we can give it to the patient directly, and they can start downloading it on the phone. Using this Eye Protector, if you will activate, see that those two pages on the one of the left, start, if you will push the button of start, it will gives you every 20 minutes a message, shows clearly that you're asking the users that you are using your device for 20 minutes or more, so you need to get rest from this device and blink. So he will be remembered to blink. And that's very important, very effective tools that we are using. In addition to that, and to conclude, that effect of the anti-inflammatory is crucial in a dry disease, in which the inflammation play a key role in its causes, include all MGD and the mucin deficiency. It's important to treat the inflammation in dry eye disease and stop the vicious circle of the dry eye development. Steroid is a very potent anti-inflammatory, but cannot be used for a long term. Zydra drops or liftigrast is a safe and effective anti-inflammatory to treat dry eye disease. Different anti-inflammatory medication can be used to control dry eye disease alone or in a combination. Now, the last term that I need to say here, Osama mentioned few important issues related to the lubricant tiers that we need to use it in MGD that should contain a lipid, because if we are treating the meibomian gland deficiency and we are giving only aqueous hyaluronic acid, there is no any benefit from it. In my condition, I'm using the drops that having hyaluronic acid and lipid and carbomere or methylcellulose. The effect of carbomere and methylcellulose is important in those cases, especially when the breakup time less than 10, because carbomere and methylcellulose, they are changing the corneal surface epithelium from the hydrophobic to hydrophilic, so making the epithelium wet and get benefit from the hyaluronic acid that we will use. Great, thanks for all, and I'm very sorry to be late. Thank you.
Thank you so much, Dr. Safwan, for this excellent presentation. And now I would like to introduce Dr. Ahmad Alilu talking about Epiphora in dry eyes.
Thank you, Dr. Isam, for the introduction. I will, my presentation actually will be a little bit short because my colleagues have covered the majority of the topics. Can you see my screen?
Yes, sir.
Okay, Epiphora in dry eye actually looks like an introductory topic, but in real life, it's quite common actually. Epiphora, in definition, has a couple of types: deficitory, reflex, obstructive, and hypersecretory epiphora. But in real life, almost 11% of all epiphora's cases are seen in dry eye. We have two main categories: the excessive tearing or the reflex tearing one, and the inflammatory punctum stenosis type. The reflexive tearing as a compensatory mechanism, actually in dry eye with decreasing mucus layer, usually there is some spilling of the tear film. And how do you figure out that? The diagnosis depends on very low tear breakup time with good lipid layer at ocular surface. We can see a healthy eyelid with open punctums and normal lacrimal passage. Unhealthy corneal epithelium is usually affected. If we can see here, as Dr. Safwan mentioned, we are having a very unhealthy anterior or corneal epithelium. The management for this type, depending on, along with the steroids, anti-inflammatory and lubricant, secretogagus medicine are promising, like cribaminide. And in my personal experience, promyxine as secretogagus is quite beneficial because it's available in the market here. The other type is the chronic ulcerative nephritis, when we have a severe MDD with inflammation. Of course, we all know the signs of MGD, like increased anesthesia, diffuse eyelid edema. We can see here the meibomian gland dysfunction, and eventually we have a severe eyelid edema which obstructs the punctum. In this type of obstruction, we can see that Epiphora become a serious problem and difficult to tackle. In these cases, we can figure out these types of membranous type of lacrimal punctum comparing to the normal slit or just, I would say, pinpoint that. So how we manage this problem? We have two different levels. We need to control the inflammation, and then we need to have some temporary relief of the Epiphora. Controlling the inflammation, my colleagues has already talked in details about the good eyelid hygiene, the steroids, the antibiotics, the lubricants, the new modalities as IBL and the Lipiflow. But in my experience, the temporary relief of Epiphora is very effective tools like punctum dilation, penetrated punctum plug, dilatation with mini Minoka, and rarely we can end up with punctoplasty. So this is perforated punctum plug. It is a short piece put in the punctum plug, and sometimes it might trigger some granuloma. That's why in a few centers they are mixing it with the use of mitomycin C. Mini Minoka also can be used in certain cases where the stenosis not only in the punctum but also in the short canaliculi. So mini Minoka also can be adjusted to be beneficial here. Finally, punctoplasty might be eventually needed in case it becomes a permanent obstruction. One snip procedure is become more common than 3 snip procedure nowadays, and both have their own indications. I have Dr. Isam who can benefit from his experience in this issue. I would like to thank you and thank everybody for being here.
Thank you so much, Dr. Ahmed, for the nice presentation. And if you allow me, I will now speak about one of the surgical methods in the cases of ocular surface disease, which is corneal neurotization. As my colleagues have just described, the corneal epithelium plays a major role in the function of the cornea and in the tear film. Actually, the cornea is one of the most dense populated structures in the whole body. By corneal neurotization, we mean restoring the corneal innervation in cases where the corneal sensation has been decreased or lost. The cornea is the most densely innervated tissue in the body. It's almost 600 times more sensitive than the skin. And this sensation is needed to feel dryness, pain, and is needed also physiologically for some functions like the blinking and the tearing reflexes, and more importantly for corneal wound healing. There is a symbiotic relationship between the corneal epithelium and the nerves. If the nerves are affected, the corneal epithelium is unhealthy. And if the corneal epithelium is affected, the nerves gets unhealthy. So there is a symbiotic relationship between them. Both are needed, each one is needed for the function of the other. As well as that the innervation is needed for a motor reflex, which is blinking. As you have just said, it's a very important mechanism to protect the cornea and to spread the tears, and for the actual secretion of the mucin cells, the goblet cells, and the lacrimal gland. So corneal innervation plays a vital role in corneal physiology and function. We have more than 50 nerves ending as nerve endings in the corneal epithelium. If patient has also facial nerve affection and lag of thalamus, then this is a double hit. We have exposure with loss of sensation. What causes diminution of corneal sensation? We have some systemic disease, diabetes, multiple sclerosis, leprosy, injuries, chemical and thermal and traumatic eye injuries. The ocular surface diseases, the famous one, Stephen Johnson, cicatricial pemphigoid, long-term contact lens use, topical anesthetic abuse, neurosurgical tumors and neurosurgical procedures that affect the trigeminal nerve. And a lot, unfortunately, of the brain tumors and surgeries for brain tumors have to sacrifice the trigeminal nerve and sometimes the facial nerve as well. What is really important and pushing this area is nerve transection that we already sometimes do during our surgeries, particularly during refractive surgery, and rarely congenital trigeminal anesthesia like in golden heart syndrome. There is a classification for the corneal sensation and the loss of corneal and diminution of corneal sensation, the McKay classification. Stage 1 with early disease with just punctate keratopathy. Stage 2 where the disease progresses and the stroma becomes affected. And stage 3, which unfortunately can end in corneal ulcers and stromal melt and perforation. The usual therapy for loss of corneal sensation was to protect the ocular surface with all type of lubricants, bandage, contact lens, sometimes tarsorrhaphy and amniotic membrane transplantation. Now with corneal neurotization, we are trying to restore the nerve supply to the cornea, whether directly by bringing directly another cranial nerve to supply the cornea. This is usually from the surrounding, so the supraorbital or the supratrochlear, or indirectly by placing a nerve graft between the corneal limbus and the supplying the donor nerve, which is probably the supraorbital from the same or from the other side. These donor nerves are the supraorbital, infraorbital, or supratrochlear from the same or the opposite side, depending on the pathology. If the whole trigeminal nerve is affected, we have to take from the opposite side. And unfortunately, this is usually the case up till now, that most of the cases we need to take the nerve supply from the contralateral side, usually the supraorbital, because it is thicker and has more nerve fascicles. So thicker and denser nerve fibers are preferred. A new terminology is called coaptation. Coaptation means placing a nerve graft, a nerve channel conduit between the supraorbital nerve or the supratrochlear and the corneal limbus. This nerve can be placed either side to side or end to side. We usually try to get a long nerve like the sural nerve, but the greater auricular nerve can be more familiar for ophthalmologists if they need to harvest it. Actually, up till now, a general or a plastic surgeon would harvest the sural nerve for us, like I will show right now. And the sural nerve can give us about 20 centimeters of nerve grafting. So it makes it much easier, and it allows us to get a donor nerve in any area in the face. Then one end is attached to the supraorbital, for example, and the other end is attached to the limbus. This attachment can be with 10-0 sutures or with glue. So we dissect and mobilize the nerve graft, the sural nerve, by a plastic surgeon. We, as oculoplastic surgeon, we dissect and get the ipsi or contralateral supraorbital nerve through a direct subbrow incision. Then we do the coaptation. We place the sural, one end of the sural nerve, end to end or end to side to the supraorbital nerve. We started by using 10-0 nylon. In the last case, we used the fibrin glue, and both are doing well. Then we tunnel it from the opposite side to a lid crease incision. We use a right facial needle, the one that we usually use, for example, in transnasal wiring or in frontalis sling operations. So we pass it from the contralateral side using the right needle to a lid crease incision. Then we pass it from the lid crease incision to the superior conjunctival fornix and place it under the conjunctiva until it reaches the limbus. When it reaches the limbus, we either fixate it at 3, 9, 6, and 12 o'clocks with 10-0 sutures or with glue. We do this just behind the limbus, and we allow the fascicles to touch the sclera. Some people even embedded in corneoscleral tunnels to allow them to grow and invade the cornea over the period of 6 to 9 months. At the end of the surgery, we close the lid incision, we close the conjunctival incision, and we do a tarsorrhaphy to allow for healing. The procedure results in increased corneal sensation. First of all, the patient will notice the increase in the subjective sensation and tearing. Then the clarity of the cornea starts to improve, the corneal vascularization starts to decrease, and the last thing to happen is that using the Cochet anesthesiometer, the corneal sensation, we can measure it again. It usually takes 6 to 9 months. Some reports say it takes up to 2 years. Patients have improvement in the visual acuity, in the sensation. However, the sensation is the last thing to improve actually. But the visual acuity, the clarity, and the amount of corneal vascularization improve a lot. If the patient needs keratoplasty, then a successful keratoplasty can be done after corneal neurotization is complete. We have done actually 5 cases up till now. The first case was just before the epidemic, and we lost the patient to follow up. Then we did in the last year 4 more cases. The first one has almost 1 year post-operative now, and it is the result with this one that actually encouraged us to proceed with the rest of the cases. He had excellent result. The clarity of the cornea improved. His vision acuity improved. The last 3 were done in the last 3 or 4 months from November till now. We're hoping and we're keeping them follow up, but we have a lot of hope in this procedure to be added to the armamentarium in managing ocular surface disease, which is by itself is a really difficult disease to cure. Thank you so much. I think we're now done, and we can open for discussion from the panelists and to answer questions. So if the panelists would like to comment or ask questions.
Dr. Sam, that's a very good, interesting case, really. I'll leave it to Dr.
Dr. Osama?
Yeah, I'll leave it to Dr. Rahid because he joined us, so I'll leave it. He wants to see something, so.
I'm joined.
Dr. Shuki?
Yes, I can hear you.
Okay. Do you have any comments or questions about corneal neurotization or any of the other topics discussed? Or you're joining for the next session, huh? Okay, any other comments or questions? Dr. Ahmed, Dr. Safwan?
Well, I think that neuralization of the cornea is an important topic that I'm hearing it from your side. It's the second time, and still I'm interested to see the details of the surgery. I thought that in this session we will have at least an operative issues that will go quickly to show us how you are doing it. So in my opinion, that we need to see this surgery, and we are all, especially I think that Dr. Imad or others, they are interesting to do it in case of some cases of neurotrophic corneal ulcer. But I'm just repeating that in our cases of dry eye, that the current that we have, I felt that when I gave them this eye protector application, most of them they present after 1 month and they are using it, and they were using it, and yeah, I think that this is the important steps.
Yeah, so, it's because of the time I had to shorten the presentation. But
exactly. See, but
sure.
an importance of that, because the steps of it need to be shown in a way that we can see these steps, because very important.
Okay. It's a 2 hours procedure.
Yeah. Do you use any growth factor or something, or amniotic membrane over to promote more healing?
Unfortunately, no. Again, I had to shorten. We don't have the growth factors, but what we are doing, which is off-label, is that we're using serum eye drops with the patient in replacement of the growth factor. I know this is not the traditional, but that's the only thing that is available right here.
Thank you. It's an interesting topic, Dr. Isam. Thank you.
Regarding the other topics, any comments or questions to the panelists? We have like 2 more minutes, but if we're all satisfied, there's no questions, I would like to thank all the panelists for this nice discussion about ocular surface disease and dry eyes, which is, again, the hot topic in ophthalmology. And I would like to thank the organizing committee and Dr. El-Amri for giving us this chance. Thank you all, and hope to see you in person very soon.
Okay, thank you.
Thank you very much.
Thank you very much.